Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. So for a patient who attended with bilateral fully occluding dead skin, keratin and debris, the right ear, which is the ear that we're in at the moment, was the worst of the two. And in this ear, the patient had also been using hydrogen peroxide drops. If you've been watching my channel for long enough, you would know that I'm not a big fan of hydrogen peroxide drops. It tends to turn, whether it's wax or keratin, into a mushy mashed potato consistency, making it very hard to suction as a result, because it keeps blocking the suction probe. Now, the outer surface of this dead skin is quite crusty, so I wasn't able to get a suction grip. It's almost like it's been baked. So if you imagine you're baking a cake in the oven, and the top part of the cake or loaf of bread is crusty, and then the core is softer. So somebody with this plug of skin and wax, the outer surface, so the lateral surface facing me was quite crusty. So I've just used an ear hook just to disturb the surface, which will then enable me to suction. So sometimes with an ear hook, the idea is not to actually remove the wax in one piece. If it comes out in one piece, fantastic. No one's going to be complaining. Sometimes, however, you can see the core of this is quite crumbly. So I'm just using the hook just to break it up into little pieces. It's almost like a hammer and chisel effect that we're going for. And so I've broken into quite a few pieces now. So I'm just returning with the suction probe. Let's see, slowly but surely I'm bringing this forward. It's a bit peculiar today. We had a phone call from someone who was inquiring about coming to the clinic for treatment. They've been watching my videos, and they asked my clinic manager, and they said they've been doing the research and they've been watching my videos. And I said, do I perform microsuction? And my clinic manager said, yes, if you've been watching the videos, you'll see that he uses suction. And they said, it was, I find it quite amusing actually, that, we don't know if Neil performs suction because he talks over his videos, so we can't hear the suction noise. We don't know whether it's suction. And I found it a bit amusing because obviously, you can actually see that I'm suctioning, and I'm actually mentioning most of my videos as well that I do perform suction. So yeah, a bit of an odd phone call, but never mind. So I've removed the more lateral keratin debris, and this is a bit more medial. It's quite this bit on the left that I'm removing off the posterior canal wall. So when we say posterior, I mean the back part of the ear canal. This was still quite crusty. It's almost like it's been baked in the sun, whereas on the right hand side, the other side was quite spongy. So I think I'm going to go back in with the ear hook, if I remember correctly. Yeah, there we go. And I'm just trying to glide it on the posterior canal wall. Now, we are on the bony portion of the ear canal there, so we've got to be careful. We don't want to make contact with the ear hook against the canal wall, especially the inner 2/3 where it's bony and very sensitive. But the idea is just trying to remove this crusty. You can see, I think I have there on the left-hand side. There is a lot of dead skin build-up here, so the patient's ear canal and the outer of the eardrum, as it's shedding dead skin, it's just collecting in the ear, it's not migrating. Very early signs of keratosis obturans. But the patient is suffering from otitis externa. Otitis externa is an umbrella term for an outer ear infection and or inflammation. It encompasses many conditions of the ear canal, the outer ear canal. In this case, this patient's got more ear eczema, psoriasis, and they have already been prescribed some spray, some antibiotic spray, and it just made sense of them clearing the ear first before using it. Let's see, just on the anterior canal wall, we're just trying to peel this slowly off the bony part of the ear canal. You just see the fantastic view we get when an endoscope, the field of view, we can more or less see the whole ear canal and plug of dead skin and keratin in one single shot. You see it's a lot more white debris here, so this is fresher layer of skin that's shedded and died. So freshly dead skin, it's white in appearance, slightly translucent, and as that oxidizes it turns into a light yellow, then a kind of a golden orange, and then dark brown, and eventually almost black in appearance, just like earwax, very similar. But earwax starts off a light brown as opposed to dead skin, so we can start off in a white colour. So this is impacted on the patient's eardrum, So we're just slowly manoeuvring it outwards. See, we can see the posterior half, so the back part of the eardrum. This keratin debris is lodged in the anterior recess. So near the eardrum, the ear canal naturally narrows and it widens again, and it creates two recesses. You get an inferior recess, which is a trench near the bottom of the eardrum, so almost like a basin. And on the right-hand side of the ear canal, in terms of if it's the right ear that we're examining, you'll have a little trench, a little recess there. We call that the anterior recess. Obviously in the left ear, it's the left side near to the eardrum, the anterior canal wall. So when we say anterior, we mean the ear canal wall is facing closer to the walls of the nose, the posterior to the back of the head. The eardrum is fully visible now, just some debris. So as I mentioned earlier, the patient had been using some hydrogen peroxide drops. So the drops had penetrated deep into the ear, and it's turned some of this dead keratin near the eardrum into a mushy consistency. So it's going to get as much as we can safely as possible. It will naturally dry up. I've advised the patient to avoid using hydrogen peroxide drops. There we can see it's just in the anterior canal wall, just slowly hovering over the debris and dead skin. Again, I'd just like to thank you all. Been reading some of the comments, all worried about my cough. But you notice I'm slightly coughing less now that I've mentioned it. I probably will cough. And I think I need to go on a vocal rest, because it's just whenever I talk, I start coughing. Otherwise, I don't cough at all. So I think my vocal cords have been really pushed to the limits. Here we are, because I've just been talking about it. From being from an Asian background, love my Indian tea, so I've been drinking loads of Indian tea. Put a lot of ginger in there, a lot of cloves, cardamom, also a bit of honey. So that has obviously helped a bit. So anyway, enough of my annoying cough. Back to the left ear, so we know we're near the entrance now. The patient hadn't been using any drops whatsoever in this ear, and you can see the texture, the consistency is a bit firmer. It's less mushy than the first right ear, which in some respects is easier to remove because it comes out in larger pieces. It doesn't block the tube as much. You see this tail of keratin that we're just peeling away. You can see the patient's outer cilia, the hairs that are normally on the posterior concha canal wall. So when you go into the ear canal, the first bend on the back part of the first bend, the cartilage, we call that the posterior, the back concha, which is near the entrance, cartilage. That's where you get the majority of the hairs. You can see it's on the right hand side, most of these hairs. It's not to say you don't get it in the rest, but here, just to the right where the suction probe is here, on that cartilage, that's the posterior concha cartilage. So you can see I'm just bringing this. I kind of joked with the patient afterwards, it looked like a prawn, the shape of it. I don't know if you saw that, it was a bit circular. And so did this last piece deep in the ear, so we're calling it shrimp earwax. Again, that's probably going to be the name of the title of this video, shrimp earache removal. Yesterday, if you watched my other video, I was comparing the wax, big boulder of wax that I removed, and I did a close-up to a meteorite, and then from there I got onto Armageddon, because that big meteorite coming towards Earth, it had a similar shape. It was all rough, the exterior surface. So this piece also looked like a shrimp or prawn. There's the patient's eardrum, textbook eardrum. You can see the incus as well. I'm just going to mop up with a fine end near the entrance. Bit of dead skin here, just on the base of the lateral canal wall. I did try and peel that, but it's quite stubborn, so I left that. We don't want to. It's just at the border, actually, of the cartilage and bony part of the ear canal. So the patient may have a bit of benign osteotitis. So the skin that lines the ear canal here can be in the core of it, elevated and off the bone, and it can expose the bone a bit. So yeah, it's just on the border of the cartilage and bone, this. So I just left that. It's not going to cause the patient any problems. Obviously, we just want to avoid any water in there. But I think just under where I'm peeling the skin up, you can see the bone there is exposed. So we just want to leave that. We call that benign osteotitis.